Very good. All right. So, welcome back once again, and good morning, and good evening, and good afternoon, wherever you are. So, we are going to talk about the pharmacology session again, but today we are going to talk about beta blockers. So, we will see what kind they are, what are the important things to remember, and then we will go into application into questions. Okay, so that's the plan today. So, I hope you remember how we talked about in the past few weeks of pharmacology classes. We talked about the nervous system, right? So we talked about how there is sympathetic and parasympathetic nervous system. And then, we started from the central nervous system, the peripheral nervous system, and then further divided. And then it comes to sympathetic and parasympathetic. And we said the sympathetic nervous system is the one which is like the fight or flight, and epinephrine and norepinephrine and all those things. And the parasympathetic is more like rest and digest, right? So all these blockers, all these receptors which we talk about, alpha receptors, beta receptors, they get activated by the sympathetic system. So it's the neurotransmitters, the epinephrine, norepinephrine, or we say the catecholamines. Okay, so it says here too, the catecholamines, which are our epinephrine, norepinephrine, those things, they are the ones which are going to activate these receptors. So alpha receptors are there for the construction. So just like that, the beta receptors will also get activated by the catecholamine release, mainly like, the body's way of handling everything, especially when there is a fight or flight situation. Okay, now what can we do to use them? Or how can we use it to manage the conditions? That's what we need to understand from, for understanding the pharmacology part of it, right? So we will go there, but we need to know where these receptors are situated and what do they do when they get activated by catecholamines. So understanding that will help us to use it in terms of disease conditions, okay? So I'm going into a little bit more kind of the basics first and building it from there. So that way you don't have to memorize anything because you already understood everything how it works. So it will make sense. It will make more sense and you will be able to remember it better. Okay, so going to beta receptors, there are three kinds of beta receptors. There are beta 1, there are beta 2, and there is beta 3 also. But we don't want to talk about beta 3 because it's not important when it comes to NCLEX questions. So we are just going to keep it in the side. Now, beta 3 receptors are there in fat tissue. They help in the fat maintenance and digestion and how they help with the entire body system, lipolysis and all those things, but it's not that important in NCLEX, so we are just going to leave it just like that. Now, so beta 1 and beta 2, they are very good receptors, works very great. Really, really helpful in maintaining the body's function. And beta 1 is especially important because it is in heart and kidney. And we know heart and kidneys are super important in maintaining the blood pressure, in maintaining the cardiac output, which is kind of the basics of, how our body and our organs get the blood and the oxygen and the entire function. So beta 1 is super, super important. Now, it is present in heart and in kidney. Okay, what does it do in heart? Like beta 1 receptors, okay? The receptors, why are they in the heart? What are they doing? Why are they there? Because they make sure when the catecholamines get released, when the fight or flight kind of situation comes, this beta 1 receptors in the heart is going to get activated and it is going to make your heart rate go up. It is going to make sure that the contractility of the myocardium, like the force of contraction of the myocardium, it is going to make sure it's going to be really good. Okay, now why? Because when we have this fight or flight situation, we want our body to be ready, right? We want our heart rate to be, you know how we feel when there's like, if there is something you are seeing which you are scared of, or if there's a fight or flight situation, you know, there is a car coming directly like towards you and is going to hit you, I mean, like that. What are we going to do? We are going to jump out, right? We will have all the energy. Our heart rate will be up. We can actually feel our heart, the chest palpitation sometimes, right? So that is what happens when beta 1 receptors get activated. It's a good thing because we need more cardiac energy. We need more cardiac output. We need more force of contraction and cardiac output and oxygen and everything to do the thing we need to do instantaneously. That's what it's going to help us with. So it's a good thing. So beta 1 in heart gets activated, increases the heart rate, increases the blood pressure, blood pressure in the sense, contractility and cardiac output, it goes up. So it's all good. Now, what does it do in kidney? In kidney, there is receptors present in kidney also. And those receptors, when they get activated by catecholamines, it is going to help or ask the kidney to produce more renin. I think we do talk about that in cardio too, but I'm sure in the renal system we talk about that with the renin, angiotensin, aldosterone mechanism, right? I'm not going to go into detail right now because it's itself going to take some time. But if you are in renal system, I believe it's in renal system, you will be hearing those lessons and videos. Okay, so it will help you. But ultimately, what happens is when there is renin, when the kidney produces renin, it is going to help in increasing the blood pressure. Renin is the first step in increasing the blood pressure. So that's the renin, angiotensin, aldosterone mechanism. So what happens is in the kidney, when it gets activated, more renin is produced. More renin meaning there is going to be more blood pressure. So basically, when the beta 1 gets activated, there is going to be more heart rate, there is going to be more blood pressure, there is going to be more cardiac output, there is going to be this, okay, bring it on, I can fight. Okay, that kind of readiness is going to be there. Good? So that's beta 1. Okay, now what is beta 2? Beta 2 receptors are mainly present in lungs. They are present in smooth muscles of the lungs too. I mean, in everywhere too. But when we talk about it, we say it's mostly present in the lungs. Now, what does that do? So if beta 1 is all about activation and increasing blood pressure and readiness, beta 2, when it gets activated, it is more relaxation. So beta 2 receptors in the lungs, when they get activated, the lungs are going to have more bronchodilation. I mean, not lungs, the bronchus, everything which is giving all this oxygen, everything into the lungs, it's going to be more open. Now, why is that? It's because when you have, more fight or flight kind of situations, you really need more oxygen coming in to the lungs, right? Because you're going to breathe faster, you will need more oxygen, right? How can you get more oxygen into the lungs? By dilating the bronchus. So it's a good thing when they get activated, you get more bronchodilation, you get more oxygen. Now, that's the main part. Now, speaking of beta 2, it is also present in uterus, and it relaxes the uterus. It is also, uterus meaning the myometrium of uterus. The uterus is also a muscle, and there is this endometrium, which is the innermost lining of the uterus. But then there is a myometrium, which is the muscle of the uterus. So because it is also present in that smooth muscles, in that muscles of the uterus, that also gets a little relaxed. But there is not much which we need to remember from an NCLEX point of view about how beta blockers affects uterus because there is a lot of studies still need to be done on that. Like we don't give beta blockers to relax the uterus, okay? In fact, if someone is pregnant and let's say they are hypertensive, like, preeclampsia or something like that, and if they have been given beta blockers, there are so many studies which says that the baby might be getting affected. Like there could be, how you say IUGR, like intrauterine growth retardation, like the baby's growth might be delayed, and there could be bradycardia, like fetal heart rate may be going down. So there is more like problems which seems like which are present. So that because of that, still it's not really like we don't know yet much about how beta blockers are going to be helpful in relaxing the uterus. Beta receptors are there in liver, and it helps to increase the glucose levels. Now that makes sense, right? Because when you are like in a fight or flight, first of all, you need more heart rate, you need more blood pressure, you need more oxygen, so bronchodilation, and you need more energy, you need more glucose, right? So because you are like in a fight or flight. And that's why probably beta receptors are there in liver too, because we know liver is the one which kind of keeps all that glucogen, the glucose stored as glycogen. So we can get some of that energy back. So this beta receptors, when they get activated, they are going to do glycogen lysis, glycogenolysis. Lysis means breaking down. So glycogen is the way it is storing the glucose. So that's going to be like broken down. So we get more glucose, more energy. But it's not that simple. Okay, there is these hormones which are going to play a big role in there too. The pancreas has a big role in that too. So it's a combination stuff, but it's there. Okay, but for NCLEX, what we are supposed to be really, really aware about, or we really need to know about, is how beta 1 is in heart and beta 2 is in lungs. So, what are the types? That's what we are going to talk about first. When we talk about beta blockers, what are the types of beta blockers available? Now, there are two major kinds. One is very, very selective. And when we say selective, I'm talking about it's just for the heart. Okay, it's called cardioselective. Cardioselective meaning it is going to activate only the beta 1, or it is going to block, it's beta blockers, they're going to block. So when it is cardioselective, it is going to block only beta 1, which is in the heart and the kidney. Okay, now these are the examples of that: metoprolol, atenolol, and esmolol. Oh, by the way, we all know that LOL, anything which ends in LOL, we know that they are beta blockers, right? So metoprolol, atenolol, esmolol. So those lols are the main one. But these you will see, metoprolol especially, you will see a lot in use, especially with patients with cardiac problem. And that makes sense because they are very, very selective to beta 1. So that what that mean is, because beta 1 is only in in the heart and the kidney, because they kind of deal with the heart rate and the blood pressure, blocking that will kind of bring them down. So when you block beta 1, your heart rate is going to come down. The myocardial contractility, or the workload of the heart, is going to come down. The cardiac output can come down a little bit because the workload of the heart is a little down. The kidney, it is going to reduce, it is blocking, right? Beta blocking. So instead of increasing the renin production, because we are blocking it, it is going to decrease the renin production, which means we can use it to decrease the blood pressure, because more renin, more blood pressure, less renin, less blood pressure. Okay, so that's how it's going to help. So that's the cardioselective or beta 1 selective. Okay, so the blockers which we are going to use: metoprolol, atenolol, and esmolol. Good so far? Okay, now there is other one. The second type is non-selective. Now non-selective, actually these two together, they all are non-selective. I just made it into one more. I will explain to you why. Non-selective ones are, it is going to activate or block, because we are talking about the blockers, right? Beta blockers. So when they are non-selective, it is not only going to block beta 1, it is also going to block beta 2. Okay? The examples are propranolol, nadolol, timolol. Actually, timolol you will see more in glaucoma. The intraocular pressure, you must have seen timolol eye drops. Okay, that's a beta blocker, but it's mostly used as eye drops to help with the people with the pressure in the eyes, which is glaucoma. So it's very helpful. But those are like, non-selective. Okay, and carvedilol and labetalol are also non-selective, but I just made them into another group. They are non-selective actually, but I just made it into another group because they also extra, not only betas, beta 1 and beta 2, it also affect alpha receptors. So it's kind of a total stuff which they are going to affect, carvedilol and labetalol. Okay, so what happens when beta 1 and beta 2 are getting, blocked? We know when this is going to get blocked, okay, beta 1, we already talked about that. When this is going to get blocked, heart rate is going to come down, workload or myocardial workload is going to come down. When this is going to get blocked, renin is going to be decreased, which means blood pressure is going to come down. Okay. Now, when beta 2 is getting blocked, instead of bronchodilation, there can be bronchoconstriction. Okay. Now, that is a problem because if we are only using cardioselective, there is no problem here. But if we are using something which is blocking both, non-selective, like propranolol, okay, or something which is more like acting everywhere, it is going to produce bronchoconstriction. Now, these two may not be, like I said, we are not much into it because still there is a lot of research needs to be done and the effect is not that much, but it really affects on the lungs when it block that. So what is the problem here? Now, what if someone has asthma? What if someone has COPD and we gave a beta blocker, which is, non-selective? What is going to happen? Yes, their blood pressure will come down. Yes, their heart rate will come down, but they will also end up having bronchoconstriction, which is not going to be good when it comes to asthma and COPD patients, right? Because it's not going to help them. That's why we have to be extremely careful when we are using non-selective beta blockers. Good? Okay, let's go back to it. We'll talk about that more. So beta 1 blockers or cardioselective one, okay, those ones we can really use in these kind of situations because it decreases heart rate, it decreases the conduction. Oh yeah, that's another thing which happens. You know how the impulses are getting conducted from SA node, it goes to AV node, and then it goes to the bundle of hairs and bundle branches, the right bundle branch, the left bundle branch, and then and we talked about AV blocks in detail, like type 1, type 2, and all those AV blocks or complete heart block and stuff like that. So this is going to be something which we have to be careful about because when beta 1 blockers, cardioselective blockers, they will decrease the heart rate, they will decrease the blood pressure, but they will also decrease the conduction, the electrical conduction. So we have to be extremely careful with that. Okay, now it can be used because if someone is having, let's say, atrial flutter, or someone is having some kind of dysarrhythmia where the rate is so bad, and the conduction is like too much conduction going on and we need to reduce it. Okay, like there's a lot of electrical impulses which is like chaotic and we need to control the rate, we need to control the conduction, we need to reduce it. This one will be helpful because we know beta 1 can be blocked and everything will come down. So it can be used in dysarrhythmias. Okay, makes sense? So we can use that. Okay, we also know the beta 1 blockers or cardioselective one, we know we can use it to reduce the renin. So it reduces the blood pressure. So we can use it as an antihypertensive. We also know it reduces the workload of the heart. the myocardial contraction and cardiac output and all the workload. It reduces that. Now, that is something where we have to be kind of careful, because we don't want to reduce the workload of the heart to a point that there is not enough cardiac output. Okay, that's we don't want to do, but we can, in some cases, a little bit of reduction in the workload of the heart is actually going to be helpful. For example, in heart failure patients, we know what heart failure is, right? We know it's the pumping of the heart is failing, and we know the heart is not able to get all that workload. It is not able to take care of that workload. So a little bit of reduction in the workload for a heart failure patient is actually beneficial, because if you don't do that, they're going to go into complete heart failure, right? Complete problem, fluid retention and pulmonary edema and all those things. So in those cases, maybe we will be able to use these beta blockers to reduce the workload of the heart. Okay, so heart failure, it's helpful. The same with MI. Because in MI, myocardial infarction or a heart attack, we know there is myocardial ischemia, or sometimes really bad MI, there is myocardial infraction, right? So the myocardium need some time off to rest and recover. So the myocardium need a time after an MI, we need a time where the heart workload can be reduced a little bit so that the myocardium can rest and recover, and it can be used for that. Right? Now, we have to be extremely careful. We don't want complete no workload. That's not going to be okay, because we don't want the cardiac output to be really bad, badly reduced. We just need to do it on a case-to-case basis. And that's why doctors are going to continuously monitor the blood pressure. They will be asked to do regular follow-up visit. We might be doing echocardiograms, maybe, on a regular basis on these patients. And the dosage will be adjusted according to how the patient is feeling. So all those things are considered, because we need to have a balance between, reduction in cardiac output, reduction in workload, and having the benefits of it. Okay. One more thing, it can also reduce the myocardium oxygen demand, because whenever the workload is low or workload is a little less, we know that they don't need a lot of activation and oxygen demand. So what we can do is, it will help in cases where there is pain, angina, especially stable angina, chest pain. Okay, so these patients, we can give this medicine to decrease the myocardium oxygen demand. Good. So they are very, very helpful then, right? The beta blockers are awesome medicines, but we need to be really, really sure that we have a really good medical history of the patient, because if they have, some kind of COPD or asthma or something where this bronchoconstriction can be a problem, we need to be careful. I mean, if they are using cardioselective or only beta-1 selective blockers, then maybe it's okay. But if they are using some non-selective ones, or carvedilol or labetalol, something like that, it can cause bronchoconstriction and it can be a problem. Right? So is this clear? Everything which is written here, is this okay? Does that make sense? Just want to make sure that everybody are fine with it. We good? Okay, all right. So that is the basics of how these medicines act, and what are the type of medicines, and what are the things you might have to remember, right? Okay, all right. So I just wanted to mention one medicine. Does anybody remember where we use propranolol? Where have we talked about propranolol? It's not respiratory, it's not cardio. But there is another case where okay, so Sukhman is saying migraine. Yes, oh, that's true. It's an off-label use. Okay, beta blockers are sometimes used in migraine headaches, and also people who have tremors. So sometimes beta blockers are used to control that. But those are off-label uses, like additional use, we can say. But that's not what I was talking about. Thyroid, okay, that's one. Because when thyroid patients have hyperthyroidism, when their heart rate goes up, we know that everything goes up in hyperthyroid except the weight. So their heart rate might be too bad. They would have palpitations and tachycardia and all those things. We might use it, but still something. GI, where in GI do we use propranolol, especially propranolol? Anybody remember that? No, I just thought about it. I just wanted to make sure everybody knows about that. Okay, think about liver problem. Okay, portal hypertension. Yes, yes, portal hypertension. When the patients have liver cirrhosis and esophageal varices, those bulging can rupture kind of problems which happens with that portal hypertension. So in those clients, we might be using propranolol to reduce that prophylactically, so that they won't rupture. Okay, just wanted to mention that we know that. All right, so that's good. Um, let's talk about complications and side effect. Now, so not complications, sorry, contraindications. Like who are the people who should not be getting these beta blockers? Number one, just like we mentioned earlier, if it is non-selective, don't give it to people who already have COPD or asthma because they will end up having bronchoconstriction, and that's not going to be okay. So that's one. So we need to take a good history of the patient, right? Second one, if someone is already having heart block or severe bradycardia, like they are already having problems with conduction. Now, when we give beta blocker, it is going to further reduce that conduction, right? The SA naught, the AV naught, that's going to go down. So if somebody is already on, let's say, type 1 heart block or type 2 heart block, and they are already like heart rate is less, on top of that, if we give beta blockers, they might go into complete heart block. Now they will need a pacemaker and stuff like that. So that's not going to be okay. Right? So we need to be extremely careful with those kind of patients. Now, the other one is, we said that this can be used in heart failure because it decreases the workload of the heart. But remember how I said it's a balance too? So if somebody is having decompensated heart failure, which means their heart is like, it's like end stage kind of like it's extremely bad. Okay, their ejection fraction is so bad. In those cases, we don't want to give the beta blocker because their heart is barely doing, to get the cardiac output out. Now, if we block that, even reduce the cardiac output furthermore, it is going to worsen the situation. So it further reduces cardiac output, and that's why we say not in decompensated cardiac heart failure. Okay, so it depends on the situation of the client. Okay, so those are the contraindications. Now, side effects. I came with an acronym. It's SHOBA. SHOBA was my one of my senior in my school, so, and also one of my cousins is named Shoba. So if you can remember Shoba, that's the side effects or main things we need to remember about the beta blockers. S is for sleep disturbances, which is insomnia, and not everybody might have that. Some people might experience that, and it's not too bad. So probably they can do, how we talked about sleep hygiene, how we talked about making sure that they don't drink coffee before bedtime, and so there could be, or maybe they will need some kind of helpful sleep medicines to maybe mild help to go to sleep. But usually we don't stop a beta blocker because there is some kind of sleep disturbances. Okay, it is going to be a case to case basis, but if we can manage it, we will manage the side effect. Okay, now hypoglycemia. H is for hypoglycemia. Now the problem here is, how patients who are diabetic, and we know diabetes is like a chronic things, and they need to manage that at home. So most of the time, the patients who are diabetics, they know about hypoglycemia, or they know that they are having the blood sugar is coming down by the symptoms they experience. And most of the time, there are so many studies, one of the number one symptom the patients recognize, the diabetic patients recognize when they have hypoglycemic episode, the number one symptom is their tremors. Okay, their tremors and they are like their palpitations. Those are the things they usually kind of recognize as, oh, okay, maybe I am getting hypoglycemic. And then comes the sweating. Okay, so when somebody is already on a beta blocker, we know what happens to the tremors. There is probably no more tremors, right? Because it decreases that sympathetic nervous system activation. Or there may not be much of that palpitations, tachycardia, because we know beta blockers reduce the conduction, reduce the heart rate, so they may not feel that. So what happens if I am a diabetic, my blood sugar is going down, but I don't recognize it because I don't have any tremors, I don't have any palpitation. What's going to happen? My hypoglycemic episodes can be more, frequent and more problematic because I fail to recognize it. Okay, if I get really sweaty, I might, but that's not like all the people might not feel that. Does that make sense? So that's why we say when diabetic patients, when they take beta blockers, they can take it. Okay, it's not like a contraindication or anything. It's okay for them to take it, but they should know that it can mask meaning hide. It can hide the signs and symptoms, normal, common signs and symptoms of hypoglycemia. So the patient should be really aware about it. So they should check their blood sugar more often, more regularly, rather than waiting for a palpitation or a tremor to come and think about hypoglycemia. Good? Okay, so that's the explanation for that. That's the H. Now, O is orthostatic hypotension, which means, we know the blood pressure is going to come down. We know the heart rate is going to come down. So people might feel a little dizzy, right? So when position is changed or when they get up from bed, and fall risk. Safety is important. So orthostatic hypotension and related teaching is something we will have to teach the patients. B is for bradycardia, and the patient should be taught how to take blood heart rate, okay, pulse rate. So they should be taught to count the pulse rate, and most of the time the doctors will give them some kind of let's say some kind of standard order for the patients. Like if your heart rate or your pulse rate goes below 60, call the clinic and we will see if you need to take a medicine. So something like that. So the patient should know, and also should know to report it back to the clinic if in case they are having some symptoms with that. Okay, so bradycardia. The other one, like we said, in asthma clients, it can cause exacerbations if it is the non-selective one. But even if it is cardioselective, we really want to be careful and monitor, making sure that there is no other problem going on. So SHOBA. Okay, SHOBA is our beta blocker stuff. Okay, is that clear? Everything here? Are we okay with that? We good? Any question on this on what we have learned so far? Hi, Mahuda. Okay, all right. Thank you, guys. Shinsi, yes. All right. One last thing, and then we are going to do some questions. Now, what are the nursing points? I bet you know by now what are the things we are supposed to do and what are the things we should be looking at. So monitor the blood pressure and the pulse rate, and make sure that we have a really good medical history because, especially with the respiratory problems, we need to be extremely careful with that. In diabetics, we need to make sure that they know about checking the blood sugar, regularly monitoring it, not just relying on that, tremors for hypoglycemia. And the last thing, do not stop abruptly. These medicines, if they stop all of a sudden, what's going to happen? All that, neurotransmitters, epinephrine or norepinephrine can just come back, and then they are going to experience hypertensive crisis, rebound hypertension, tachycardia, heart failure, everything can happen. So don't stop abruptly. The patient should be contacting the clinic and let the doctor decide if there is a dose adjustment or there is a need to stop the medicine for whatever reason. They need to talk to the doctor first and then it will be decided. So even in procedures like surgeries and all, most of the times we know that in surgeries, most of the medicines will be stopped on the day of the surgery, right? I mean, if they are having anticoagulants or antiplatelet medicines or even oral anti-hypoglycemic medicines, most of them we will stop on the day of the surgery. I mean, they will be like NPO. But if they are taking a beta blocker at home, the newer research what suggests is it is better that they continue the beta blocker even on the day of the surgery so that they will get that cardioprotection effect. Now, it will all depend on how the patient's blood pressure is that day, how the heart rate is that day, and how everything else is. But chances are that the doctors might continue that beta blocker even on the day of surgery. All right? Okay. Let's do some questions. Enough talking. I hope the concept is clear now that you know how beta blockers act and what are the important things. So let's apply that knowledge now. So the first question says, a nurse is reviewing the health record of a client who is starting propranolol to treat hypertension. Which of the following condition is a contraindication for this medicine? I know you know the answer, but just letting you know that propranolol, what do we know about propranolol? Propranolol is a non-selective one. So it is going to block both beta 1, which is good for hypertension, but it is going to also block beta 2. Now, when it blocks beta 2, we are worried about bronchoconstriction. Okay. So which patient is going to be a problem child here? That's going to be our asthma patient. Right? Okay, very good, very good. Let's do the next one. How about this? A nurse is caring for a client with type 2 diabetes who was recently started on metoprolol for hypertension. Which teaching point is most important for this client regarding the use of metoprolol? Remember how we talked about hypoglycemia, SHOBA, H for hypoglycemia? Okay. Number 1, you should double your metoprolol dose if you notice swelling in your ankles. Number 2, this medication may prevent you from noticing fast heartbeat. So check your glucose regularly. Yeah, that is the answer, right? That's the second is the best answer here. But let's look at the third and fourth. Stop taking the medicine if you feel tired because this is a harmful side effect. No, there is no need. This should not be stopping like that, right? We said do not abruptly stop the medicine. Right? And the fourth one, you do not need to monitor your blood glucose as often while taking this medicine. That is wrong. You actually should be monitoring the blood sugar more often when you are taking this medicine. Okay, so everybody got 2 as the answer. Good job. See? Pharmacology is easy. You are getting all the answers right. Okay, there is no need to be scared of pharmacology. All right, so let's do another one. How about this? A nurse is providing discharge teaching to a client recently prescribed metoprolol for hypertension. Which client statement indicates the teaching has been effective? So whenever it says the teaching has been effective, we are looking for something good. Okay, so what is something good? Number 1, I feel more tired than usual. I will take an extra dose of my medicine. Number 2, I will stop taking this drug if my blood pressure is normal for a few days. No, don't stop the medicine. Number 3, I will drink extra fluids every day to prevent my blood pressure from dropping. Well, fluids are good, but I don't think we need to say extra fluid because more fluid is going to make the blood pressure go up, right? So, number 4, I will get up slowly from sitting to lying to avoid feeling lightheaded. Yes, so that is see, you got it. So 4 is the right answer, right? Okay, all right, good. I don't think anybody has any questions with these options, right? So because everybody are getting the right answer, so I'm just taking it as you know it. All right, next one. A nurse is reviewing new prescription for a client admitted with hypertension. The provider has prescribed propranolol. The nurse notes in the history that the client has mild persistent asthma controlled with albuterol. Okay. Which action is most appropriate by the nurse? One, instruct the client to use albuterol before each propranolol dose to prevent bronchospasm. Number two, contact the provider to clarify the prescription due to the client's history of asthma. Number three, administer the medicine as ordered because it is prescribed for hypertension. And number four, monitor breath sounds and notify the physician if the client develops wheezing after the first dose. What would you say? Good job, good job. Two is the answer. Because if it is propranolol, we know it is non-selective, so it's not going to be good to give to this patient who already have, we know that there is asthma and they need albuterol inhaler, so it's not a good medicine for them. So the answer is going to be we need to tell the doctor and clarify and see if there can be, there are so many other beta blockers which they can have, right? So two is the answer. Very good. Very good. Okay. How about this? A 59-year-old client with a history of stable angina is admitted to the cardiac step-down unit after reporting chest tightness during physical activity. The provider prescribes atenolol in addition to the client's current nitroglycerin as needed. 2 weeks later, the client returns for follow-up. The nurse reviews the client logbook, which means the client's notes and things like that. Or let's say electronic medical record chart, okay, and notes that the client has been able to complete light household chores without needing nitroglycerin. The client's blood pressure is 122/74 and the heart rate is 66. Which finding best demonstrate that atenolol is producing the therapeutic effect? Okay. So basically, it's a lot of writing and reading. I understand that, but let's make it simple. What this scenario is talking about, there is a patient who has stable angina. You know what stable angina is, right? It's when they get chest pain, when they do certain like exertion or activity, they get chest pain. They know when it is going to happen, so they can prevent it from happening. And this patient is already taking nitroglycerin for that, right? As needed basis. Okay. So now they also have, problems, so maybe blood pressure issues and started on atenolol, which is a cardioselective beta blocker. Okay. Now, the question is asking not about, all the other problems. The question is asking, and they have given us the vital signs and everything. How do you know that the patient is better, or how do you know the atenolol is working as it is supposed to work? That's what we are using. Okay, so all right. Let me help you because I saw that most of you are saying two as the answer. Is there anywhere where it said that the patient was hypertensive? Did it say in the scenario that the patient is hypertensive? It didn't say that. Okay. What is the problem mentioned in the question? Why do you think that they gave atenolol to this patient? Angina. Oops, what did I do? Sorry. Okay. It is for angina, right? Stable angina. All right. And the patient is having chest tightness, that's part of angina they feel, with physical activity. They already had nitroglycerin. Current nitroglycerin, they already had nitroglycerin, but they needed something more. Remember how we talked about the usage? Let me go back. Okay, remember how we talked about that? If we give beta blockers, we can actually decrease the myocardial oxygen demand, and that's why we can use it in angina, right? So this patient actually got the beta blocker not to manage the blood pressure, but to manage his angina because nitroglycerin itself was not enough. Okay, with that information, how do you know that this patient is actually getting the best effect or the desired therapeutic effect of atenolol? Do you want to change your answer? Which one? Okay, very good, very good. 4 is going to be the best option here because the client reports no episodes of chest pain, basically saying, oh, this medicine worked because I don't have chest pain anymore. I don't have angina anymore with my usual activities. Okay, so normal blood pressure and heart rate is an added benefit, right? But for this patient with this history, with this scenario for which he got the atenolol for, the therapeutic effect is no more angina, right? So 4 is going to be the best option. Well, 2 is technically not wrong because that's also good effect. But for this patient, the best answer is going to be 4. And you know, in NCLEX, there are some good answers, right answers, and best answers, right? And we have to select the best answer, which is very focused on the patient. Good? Okay, so 4 is the answer. Now let's do one more. So I just want to make sure that you get that therapeutic effect question right. A 67-year-old client with a history of hypertension and coronary artery disease was admitted 3 weeks ago with worsening heart failure. Okay, so he has a lot of problems. There is hypertension, there is coronary artery disease, but this time he is admitted with heart failure, with exacerbation of heart failure. All right. The client was started on carvedilol. So that's the medicine which is everywhere, acting everywhere, right? Beta blocker. And in addition, so they were already on a diuretic and ACE inhibitors. So an antihypertensive was already there, a diuretic was already there. Still the patient is going into heart failure. So we added one more. All right. Today, during a follow-up visit, the nurse reviews the client's status, which finding indicates that carvedilol is producing the therapeutic effect. Okay. How do we know that carvedilol is working? Number 1, the client walked across the living room without becoming breathless. Number 2, the client's heart rate decreased from 82 to 64. Number 3, the client's blood pressure is lower compared to baseline. Number 4, the client's ankle swelling has not worsened since last visit. Okay. I see that you are answering about 2. What is 82 means? Is 82 normal? Is heart rate of 82 normal? Answer is yes. Is heart rate of 64 normal? Answer is yes. So is there anything special going on there? No, right? Right? I mean, we are looking for something which this medicine is really helping this patient with. So is a normal heart rate from 82 to 64, is that the reason why we gave this medicine? Is that what we really want this medicine to do? No. Because what is therapeutic effect? The best effect. The really good thing which the medicine is doing. That is therapeutic effect. So what would be the answer? Okay, I see 3. Did we start atenolol, not atenolol, did we start carvedilol for this patient because he is hypertensive? Is that the reason why we started this medicine? They were already on a diuretic, they were already on ACE inhibitors. which will help with the heart rate, the blood pressure. Is that the reason why we started carvedilol? Why did we start? Why is this patient came this time to the hospital? Not for hypertension, not for coronary artery disease. He came for exacerbation of heart failure. That's when we give the medicine. We gave carvedilol because we wanted to help him with his heart failure. Okay. What are, I know some of you might not be there in cardiac yet, so this might be a little too much information for you, but if you have listened to the cardiovascular heart failure session, I bet you are not going to forget our right heart failure and left heart failure and the heart failure overall. So what are the signs and symptoms which comes to your mind when we shortness of breath? Jaswin, shortness of breath is one of the heart failure sign. The swelling is another one. Okay. Number 4 says the ankle swelling has not worsened since last visit. Is that really a therapeutic effect? If it is a therapeutic effect, what am I supposed to see? There is no more swelling. That is the therapeutic effect. Okay, not worsening, meaning whatever was there 3 weeks back, 3 weeks, right? Yeah. So whatever was there 3 weeks back is the same now. Is that a good therapeutic effect? No. I'm just trying to help you to eliminate all the options. Okay. So we eliminated 2 because that's not helpful. That's not saying anything much. We eliminated the 3rd one because we didn't give carvedilol to check the blood or manage the blood pressure. And the 4th one also we are eliminating because it just says the ankle swelling is the same as before. That means this medicine, if I give this medicine to a patient who has ankle swelling and 3 weeks back he comes down and say, oh, you know what, this medicine didn't work because my swelling is the same. That's what I am going to say, right? So is that a therapeutic effect? No, there is no therapeutic effect. So it's not 2, 3, or 4. So the answer is 1. Now, why 1? Because it says the patient is, walking across the living room without becoming breathless, which means his shortness of breath is improved because he was coming with worsening heart failure. So that shortness of breath is one of the major things which patients are going to have when they have this, worsening heart failure. Okay, all right. So good job. So 1 is going to be our answer because we eliminated all the others. So the best one which we can select is 1. Good. Okay. So thank you. It's always such a blessing to hear everybody talking and how, how good they feel after they pass the exam. It's like the biggest challenge is over. And I wish that for everyone who is here today and who is listening to the recording. So thank you. Just keep focus, and when the right time comes, you will be here talking, and talking about your journey and giving thanks to God Almighty. So that day is going to come. Just take care. Bye-bye. Thank you, guys.